Okay, so it looks like everybody's kind of joining, and it's just after 1 o'clock, so we're going to get started. Welcome to our APIC Great Lake member presentation August webinar. I'm happy to have all you guys join us today. So we're actually going to have 8 different presenters, all from our Great Lakes team. So that'll be exciting. Just a quick reminder, registration is now open for our October 15, 2026 APIC Great Lake Conference. So please register for that if you haven't yet. This year's theme is a bridge over troubled waters, and we have a lot of great speakers. This will be at the Kellogg Center in East Lansing. So please register for that. And then just a quick note, if you have any jobs that you would like to send to us, we'll post it on our LinkedIn page. So here's the email here. You can just send it to apicgreatlakes@gmail.com and we'll get that posted. And then also, once again, all our webinars will be posted on our YouTube channel, which you can see here afterward. So you can always go back and watch. So since we have a lot of speakers, we're going to go ahead and get started. So we'll kick it off with Jenny Gubler. And just to note, if you guys have any questions throughout the presentations, just feel free to throw them in the chat, and then our speakers can answer that way. So Jenny, we'll start with you.
Okay. Can you hear me okay?
Yep, I can hear you, Jenny.
Okay. I'm just going to keep talking after that. Okay. Sorry, Jason and I are in the same room, so we had to switch our audio over very quickly. So thank you for having me. So since this year, as a member of the board, one of the things that we do is we have a raffle for eligible board members to see who will get, sent to APIC for the year, and funded through the APIC Great Lakes group. So as one of the kind of requirements for accepting that funding, I've just come back to the group to share some of the kind of like comprehensive overview of the conference, talk about some recommended talks if you want to go back and watch those, if you have access, some key takeaways and things to kind of think about if you're going to attend in the future. So if you go to the next slide, please. Oh, there we go. Okay. So this year, the conference was in Nashville, Tennessee. It was really great. So it occurs typically over a Monday, Tuesday, Wednesday. Most people will come in on Sunday, but some come in on Saturday just because there are chapter leader events or other things happening on Sunday. This year, there were over 2,100 attendees from all across the country, and even some global or national or international attendees as well. I don't think this is the highest attendee list that they've ever had. I know there was like 2,300 last year, the year before, but it's still quite a few people, and it does feel like it gets bigger and bigger every year. So the a schedule of events is pretty broad, and it starts at around 6 a.m. with some vendor breakfast that different vendors will host. They'll give you breakfast, talk about their products, things like that. The general sessions or keynote speaker things typically start around like 8 or 9. And then there's a variety of different things that happen throughout the day, all through like 7:30 p.m. or even later, sometimes into the evening. So there's definitely talks. There's a huge poster area. The vendor hall this year felt bigger than ever before because there were 189 vendors this year. I think most people's favorite part of the vendor hall, though, is APIC does have different, things set up throughout the vendor hall that are not just vendors. And one of them is a puppy station. So they always partner with a local rescue. The group will bring in some puppies, and you get to play with them throughout the day. And they are so stinking cute. It's great. There are definitely evening events, whether they're hosted by APIC or vendors will put things on. So this year we attended, or my kind of group attended, a Clorox and Gojo event. That was great. They had that at Jelly Rolls Bar downtown in Nashville. That was a lot of fun. And then obviously for attending, you do receive IPUs once you submit your evaluations for each of the talks and events that you participated in. If you go to the next slide, please. So some key takeaways. So if you've never attended before, whenever I talk to somebody who's newly attending, I always kind of describe it as going to Disney World. So you're never going to be able to do everything in one trip because there's just so much going on and so much planned. So just kind of keep that in mind if you've never attended but you're planning to in the future. You definitely want to, you know, have a plan, kind of be strategic about it. Definitely use the app. So here's a couple of screenshots from the app. So they typically have it available and loaded at least a week or two before the conference. You can go in and click on the full schedule, kind of read through all the different talks. You can start anything that you'd like to do and get it on your personal schedule. So then as you're at the conference, you can click on that little square that says My Schedule. And rather than showing you everything that's going on, it'll just show you what you kind of had planned to do throughout the different days. There's lots of different features in the app, so definitely take a look at that beforehand. It's really, I think, greatly improved the conference experience versus the days when we used to just have like a printed stack of papers with the schedule and events and highlighting everything and going through it. So do take a look at that if you are interested. I think in general it's a really great experience, and I think everybody kind of gets their cup filled, if you will, from attending and kind of getting re-energized by, talking about the latest and greatest things in our field, talking to and networking with people from other areas and seeing what they're doing. Sometimes you don't really appreciate what you have until you talk to other people who don't have those things, and then you're just maybe a little bit more grateful, which is good too. But if you go to the next slide, I'll highlight a couple of key talks. So if you attended, you should still have access for maybe another, I think through the end of September, to go back and listen to any of the recorded talks. So I think almost all the talks get recorded. You can go back and listen to them afterwards once they post them to the website. And here's a couple that I attended that I thought were really great. So of course, our very own Eileen Thompson did a really great talk about the hidden risks of loaner instruments. That was pretty well attended. I thought that was great. Of course, our very own Rebecca Batches did her Mythbusters talk. We were fortunate to see it before this conference, for one of our webinars, but she did wear the beret in case you were wondering. A couple of other interesting ones. So I didn't mean to attend this. I kind of just happened upon it. But there was a really interesting talk about UV disinfection and Candida auris from somebody from Saudi Arabia. Really interesting, provocative data, so take a look at that one if you can. There was a really great talk too about doing some OR observations and how to put kind of your checklist together for auditing some of the horror stories and things that they've seen. That was a team of kind of consultants from Duke. They had a really great talk. And then I think my favorite, honestly, of everything that I saw and kind of popped into or watched was the talk on the last day by Aaron Woodall. So he talked about kind of the challenges that we can have with leadership and how to maybe approach those and overcome, or maybe the times where it's just, there is no hope and maybe we need to think about walking away. Really great talk. If we're ever looking for like a future talk or anything, like beyond the full conference or whatever, I'll just plant the seed with the education committee. We might want to talk to him about doing that talk for us because it was really great. Next slide, please. Okay, and then just to kind of wrap it up, so a couple other things to know or think about if you're ever going to attend in the future. So something fun that they do is these ribbons. So if you look at that picture in the upper right corner, so you can see there's the lanyard and then kind of your name badge that they give you. And then near kind of the check-in area, they'll have a wall of these different ribbons. And some of them are pretty straightforward, like CIC, acute care, ambulatory care, behavioral health. But then they also have funny ones too, like caffeine lover, or I think this year I had one that said like germ Jedi or something like that. But you can kind of mix and match them. You can take as many as you want or as few or none. But it's just kind of like a fun little thing to do and get people talking and kind of, comparing your ribbons. You definitely want to make sure you leave room in your suitcase for all the free stuff that you might acquire. So keep that in mind. That's like a a new person, a new attendee's kind of biggest mistake, I think, in a lot of cases. You'll also get box lunch the first couple days. They do have a variety of dietary options if you need them. You don't have to eat the box lunch, but it is provided in case you're interested. Something that people often kind of panic about is the last day. You have to check out of your hotel by 11, but the conference is still going on till like 1, 2, 3, something like that. They do have a luggage check that they typically offer, so you can bring your luggage to the conference center, check it in with our group, like the APIC group, for a couple bucks, and then you can pick it up on your way out of the conference and to the airport. So just keep that in mind. The keynote speakers are always great. They're definitely worth attending and watching. Sometimes rewatching once you get home, if you have access to the recordings. And then obviously you get your IPUs, which is always great. You get somewhere in the teens. I think it's varied a little bit each year, but definitely worth participating. Even if you just do the virtual option, if you can afford that, that's great. And then if you have people within your facility or your group of friends who have access to the recordings or the live stream, what you could do, what we've done in the past, is get in a conference room and watch some of these things together. Or what we've also done is like you can, not everybody can get together in a conference room, so you can stream it through like Teams or Zoom or something like that, as long as you're tech savvy enough to make that work. We've done that in the past too with some of my peers, and that's really been helpful to kind of help spread the information, do some team building, just kind of keep that in mind. But I think that's it for me, unless anybody has any questions.
Awesome. Thank you, Jenny. And up next, we have Micah.
Oh my goodness, that came up a lot faster than I thought. Thanks, Julie. I was definitely thinking you were going to go in alphabetical order, and I was not figuring I was going to be first. But my talk, I did a poster, and so I work at Corwell Health, and this was in relation to a water intrusion event that happened at one of our critical access hospitals over on the west side of the state. If anybody has heard of Hastings, Michigan, that's where this hospital is. It's a little 25-bed community. It's a critical access hospital, so a little itty bitty hospital. And this happened. It started on a weekend, of course. Nothing exciting is ever going to happen Monday to Friday, 9 to 5, right? So this was actually started with one of my colleagues who happened to be on call over the weekend, and she was notified that there was water in the surgery department. And that we all know that call can mean a wide variety of things. We could have a little puddle, or we could have, in this case, it was a very extensive amount of water that went through our PACU space, under the wall between the PACU and the hallway that the ORs are in. And it all started because of a failed fitting that was going to thankfully this was all clean water. It was a clean water line, and it was a failed fitting that went to a piece of equipment in the soiled utility room. So very graciously, my coworker very graciously got a bunch more information. She gave me a heads up and said, "Hey, by the way, this is what you're going to be walking into on Monday morning when you get back." My local EVS team, environmental services, took care of the initial trying to contain as much as they could before our facilities team called in an outside service. And then we let kind of the professionals take over and work on the mitigation.
Okay.
Still hear me?
Yep, I can hear you, Micah.
Okay. I am so sorry. My screen went completely black. I have been telling everybody that I have been having technology issues all day, and I don't understand because it's not my normal technology issues. So anyway, we did have mitigation that began right away. Our environmental services team cleaned up as much as they could. Our professional service was called in, and then they had to do a bunch of like poking holes in the bottom of our drywall, making sure that everything was getting dried out, fans and all of the things. So we know that we don't like holes in our drywall. We know we don't like fans. And so our facilities team set up a bunch of containment in the spaces that were affected. You can see in those pictures there that this was not a small amount of containment that was set up. So the first picture is the containment that was set up in the hallway. On the left side is the containment, and on the right side, those are my 3 ORs. So the containment and all of the work that was happening to remediate this issue was happening literally right outside of the OR spaces. That middle picture shows the amount of space that gave the facilities guys and our outside contractors to fix our problems while we were able to maintain access in the hallway for our stretchers getting back to the OR spaces. And then that third picture is on the right there is just one of the extra containments that we had that was set up at one of our scrub sinks. Thankfully, we have a couple. So if they were using this OR in particular, they just used the scrub sink from one of the other ORs and then walked the couple extra feet down the hall in the other direction to get to this OR space. But this was a very extensive amount of work. At the 48-hour mark, we still had a lot of moisture, so we had to do a lot of drywall mitigation or remediation, fixing a lot of the drywall. We had to pull out some insulation. Our facilities team used moisture meters to test the drywall at various points to make sure that the amount of water in the drywall was coming down. And then because it wasn't coming down at that 48-hour mark, that's when we said, okay, we need to actually pull it and put in new so that way we are not potentially going to have mold in our walls moving forward. So really, this was just a huge collaboration and highlighting the need for that collaboration in a multidisciplinary team. Because we needed our facilities group, our surgical services leadership, executive leaders at our hospital, environmental services, as well as infection prevention to make this all happen effectively. And because we were able to work together and come up with a solution that allowed our ORs to stay open, it was very important to us that we also monitored all surgeries that happened while this work was ongoing. And we did not identify a single surgical site infection while this work happened. And this was over a few weeks. It wasn't a quick process to get all of the contractors and everything in to fix everything. But we were very excited that we did not have any breaches of our plastic containment and there were no infections that were identified. I think that's all I have.
Awesome. Well, thank you, Micah. Great presentation there. Next, we have Jen Jones.
Awesome. Thank you. So my poster is really around improving hand hygiene in our neonatal intensive care unit. And this was utilizing a human factors approach. So our NICU is 104 beds here, split between private rooms and multiple shared nurseries. In our shared nurseries, there is no physical barrier between bed spaces, and so we were looking to improve hand hygiene compliance. And when we really tackled this issue, looked at is sanitizer in the correct places for where care is being provided. So with using that human factors lens, we did a systems analysis which identified high-risk moments and staff movement patterns. So we did multiple spaghetti diagrams looking how staff moved around the room while providing care. And then we surveyed staff multiple times on where we place sanitizer to see if the placement was in the best spot for them to use. So we asked them questions like, is this dispenser easy to use? Do you perform care on the right side of the isolette? Are you an adjunct team member and you are providing care on the left side of the isolette? We do a lot of two-person care in our NICU, and so wanted to tackle not only the primary caregiver, but also the secondary caregiver. who is there to help support baby's movement, those types of things. So all in all, it was a success with getting frontline feedback, applying those human factors techniques, and then we did see an increase in hand hygiene compliance overall. So I think that's it.
Awesome. Looks great, John. Okay, up next we have Danica.
Hello. So ours was a norovirus outbreak in a 34-bed inpatient rehab unit within a 150-bed acute care hospital. We had 8 patients that developed nausea, vomiting, and diarrhea and abdominal pain. And because of the shared space within a rehab facility, all the therapies that they do together and the high patient interactions. We were having up to 3 patients in a room, actually. This created for the spread of norovirus to go a little rampant on such a unit. So what we did was create a multidisciplinary team that included infection prevention, nursing, EVS, our physical therapists, business assurance, and then hospital administration. And we also contacted the local health department right away so that they were aware of what was happening. And we placed all of our patients in contact plus precautions. So that included gowns, gloves, and then cleaning with bleach within those rooms. And then also EVS was very important in making sure we were deep cleaning the unit as a whole, not just the rooms that these patients were in. And then the unit was closed down to visitors and also new admissions. And that was a little difficult because nursing had to make those phone calls to let families know that they couldn't visit their loved ones, which is kind of hard when you're in the hospital. So after all of that, we had a total of 39 patients that were tested for norovirus on that unit. And of those 39, 14 were positive laboratory confirmed cases, with 2 being community onsets. We created an EPI curve, which was really useful in identifying like when we have peaked in our positive infections. And then the health department's recommendations for the unit was to reopen after 7 days of symptoms free, which is a little difficult because sometimes patients would have constipation, so then they would be given laxatives, so then they had diarrhea. So then the question was it attributed to norovirus or was it attributed to the laxatives that they were given? So because of that, we were having daily huddles with the clinical staff to determine the cases and if we are still seeing symptoms. So because of those difficulties, the unit was actually closed for 18 days in total. And then after 18 days, we were able to reopen. So we learned a lot of lessons from this norovirus outbreak. One of them that was really important was early recognition of symptoms and speaking up. So if we are seeing something like this from staff or anyone else, they should like let infection prevention know so we can also do a more in-depth analysis if we are having an issue. And then also the importance of contact plus precautions and how we should all be adhering to those isolations once we do have them on the unit. And then also ongoing communication was really important between all of the multidisciplinary staff that was involved in the outbreak. That's all we have. Thank you.
All right, thank you so much. Next up is going to be Abigail, and I believe it's Jennifer's presenting.
Yes, this is Jennifer. I'm presenting this one. So our poster was related to our cleaning process for Candida auris. As you probably know, Candida auris cases have been exploding in southeastern Michigan the past couple of years. And every positive test comes with an investigation, and sometimes that investigation results in remediation measures, which may include deep cleaning of patient rooms and units. This is very resource intensive, as I'm sure you can imagine, so we don't want to have to do this too much. So to try and minimize the amount of reactive cleaning we're doing, we looked into our daily cleaning processes to make sure they're covering everything we need them to, so we're effectively preventing the spread of C. auris in our facility. So we looked at the actual steps of our cleaning process. We determined that we were addressing all of the surfaces in the patient rooms, which was great. We were still identifying some deficiencies though, so we were able to pivot our focus on creating different resources for staff to make sure they're addressing everything every time. So we created a little checklist for them, and that's been really helpful. We also looked at wipes. We had 3 different kinds of wipes that we're using hospital-wide. and we wanted to make sure they were all on EPA List P, which they were. And so we also can start looking now into the different specialized wipes we might use for specific equipment. We identified a few pieces of equipment we want to target, like ultrasound transducers, and we want to make sure we're limiting our wipes that we're using with our specialized equipment to those that are on EPA List P as well. We looked at the disinfectants our housekeeping staff uses for their daily cleans of patient rooms, and we found that those disinfectants were not on EPA List P. So we were able to identify and trial a couple of products that were on EPA List P, and we picked one that met our facilities needs, and we transitioned to that product. And then the last piece of our cleaning process we looked at was UV disinfection. Our robots, it turns out, were able to kill C. auris, but they required a longer cycle than we were using. So we were able to modify the cycle that we use our robots on to make sure they're actually effective against C. auris, as well as all of the other things we want them to kill. So once we confirmed our cleaning process was appropriate and all our disinfectants were doing their job, we were able to look at other smaller things that might get missed, like our equipment, things that aren't cleaned by housekeeping. So that's sort of where we're headed with this. The challenge is it's hard to quantify how impactful these improvements actually are, because as we increase C. auris testing at our facility, we're picking up more cases, but we haven't had to do terminal cleans quite so often in response to these positive cases. And that's it.
Awesome. Thank you, Jennifer. Let's see. Up next, we have Claire.
Can you hear me okay?
Yep, I can hear you, Claire.
Okay. All right, great. So good afternoon, everyone. This is the poster that I had presented at APIC this year. It's titled Direct Operating Room Observations, Opportunities to Create a Safer Environment. And essentially, we wanted to look more focused on our SSI prevention and all the bundles that we have in place. We wanted to perform some OR observations to assess our adherence to the best practices such as PPE usage, surgical attire, hand hygiene compliance, skin prep technique, hair removal, antibiotic timing, overall traffic within the ORs, and then looking at the management of some of our patient equipment and supplies and the overall environment. These observations were something we had done in the past, but we really kind of enhanced our process to include other participants. So we included a representation from anesthesia and then OR nursing leadership so that they could be part of those observations and help us with providing that direct feedback and really understanding the workflows and any barriers that might exist. So we included them in our observations, and we also increased or changed how we approached our feedback from our observations. So after each observation, we were sending a summary email to some of our key stakeholders that were identified with just a list of findings and any follow-ups that had occurred. And then we are also sharing these trends regularly at some of our SSI-related meetings. From the time period of March 2025 through November 2025, we ended up doing 36 total observations. And in those observations, we found that there were hand hygiene misses in each of the observations. Most commonly, it was surrounding glove use. So people were putting gloves on and taking them off without performing hand hygiene as appropriate. We also are finding a lot of misuse of gloves where they kind of are putting gloves on and doing every task under the sun. Additionally, some of the common findings were exposed earrings, beard covers not being worn when they were indicated, the hair not being fully contained in their hair covering, hair removal being performed in the OR rather than the peri-op area. We are sometimes finding blood from prior patients on equipment or supplies. Unnecessary staff entering the OR, most commonly to access supplies within the room. Inadequate technique for the vaginal skin prep. And then staff sometimes entering the ORs wearing the wrong types of masks per facility policy. And then lastly, antibiotics not being administered per facility policy. So as you can see, we found a lot of non-compliance. So we had a lot of work to do with figuring out how we could remove some of the barriers to non-compliance and how we could really improve everyone's understanding of what the policies or best practices were. So these observations are helpful and they still are ongoing to this day. It just helps us kind of gauge where we're at and implement any changes so that we can promote compliance and make sure that everyone's doing the right thing by the patient. And that is all I have. Thank you.
Great. Thanks, Claire. All right. Up next, we're going to hear from Jason. And Jason, just let me know when to advance the slides.
Great. Sounds good. Thank you so much. Thanks everyone for your time today. Today I'll be presenting our poster, which is titled Catheter-Associated Urinary Tract Infection Reduction, Turning the Tide Through a Comprehensive and Multidisciplinary Approach. Next slide, please. So really briefly, a background on CAUDIs. These infections have a patient impact, which is briefly increased morbidity, mortality, and length of stay. There's also a financial impact to the hospital, and mainly that's with our CMS reportable infections, which I'll be focusing on today. CMS will not reimburse CAUDI treatment costs, which can be about $13,000 per infection, so quite expensive. Can also count towards your HAC penalty score. So if you perform poorly, you could have a 1% payment reduction at the end of the year. So huge potential financial implications there. There's also a public perception impact as well. CAUDIs do factor into your publicly reported metrics, so that could impact your scores like your leapfrog grades, and nobody wants a low leapfrog grade. So huge impacts potentially with these infections. Next slide, please. So this is what we were facing in 2024. What we saw is an increase in our CMS reportable infections by 6. We had 0 in 2023 and 6 in 2024, so that was a pretty significant increase. Our SIR for these infections was 2.2. So that represents that we had twice as many infections than were expected on these units. So a pretty major problem that we had to address. Next slide, please. What we did is we used a PDCA methodology for this project, a Plan, Do, Check, Act methodology. And we set a goal of reducing our annual CAUDI SIR by 50% when compared to 2024. So our SIR in 2024 was about 2.2. So a 50% reduction goal would be about 1.1. In the planning phase of this project, we first did some information gathering and review. So we looked at the literature and identified best practices. We looked at our RCAs from CAUDIs in 2024 to look at trends. And then we also looked at our catheter utilization to see what was going on there throughout the years. Next slide, please. What we found was a pretty broad spectrum of opportunities for improvement. So these infections occurred on multiple units, 3 different units. Half of them were insertion related and half of them were maintenance related. And 2/3 of them were gut bacteria. So that made us think that potentially our pericare and catheter care wasn't quite up to standards. And finally, utilization also increased gradually from 2022 to 2024. So lots of opportunities for improvement in a lot of different areas. So we needed to take a comprehensive approach. Next slide, please. So one of the first things we did is we created a daily list of patients with urinary catheters. And what this helped us do is create a general shared awareness on how many catheters we had in-house and where those catheters were. We sent these to leaders each morning, included the patient's location, how long the catheters stayed in place, along with some other demographic information. And then the nurse leaders on the units were required to review each catheter each day to see if it was still indicated. And the goal of this would be to help facilitate prompt removal of these catheters. Next slide, please. The other thing we did is create a multidisciplinary CAUDI reduction team. The first phase of this team was to have the clinical team members provide information on baseline practices. At the time, I was new to the hospital, so this really helped me understand what we currently were doing to prevent CAUDIs. The second phase was to have team members provide input on what they thought was causing the increase in these infections. That really helped create a sense of shared ownership. And finally, the third phase was to establish priorities, develop interventions, and facilitate the implementation of these interventions. So you can see on the table to the right was a whole list of all of the interventions that we implemented. And really what we did is we tried to target every category of CAUDI prevention. So insertion, maintenance, removal, reinsertion, and culture stewardship. So we took a really kind of full approach. Next slide, please. Another big intervention that we did was auditing our maintenance of our catheters. So that was something that wasn't currently being done at the hospital was weekly Foley audits. And so we started that in partnership with nursing, and the findings were sent each time to the nurse leaders and managers to follow up. And what we found from this intervention was multiple benefits. We got to interact with the frontline staff. People kind of recognize you as like the cauty person, so that was kind of fun that people kind of just played along. We got to monitor trends in our compliance, and then something that really struck me was how much patients and visitors appreciated this. Whenever we would go in and explain what we were doing, all of the patients and visitors were really happy that we were doing this for them. Next slide. So these are our results. We didn't quite meet our goal of a 50% reduction in our SIR, but we did drop it by 35%, which was great. We also dropped our CMS reportable infections by 2. So we had 6 in 2024 and 4 in 2025. Next slide, please. We also dropped our utilization quite a bit. We dropped our utilization by 18% when you're looking at the SUR. Next slide, please. So we did have to make some adjustments. Every time we had an infection in 2025, we did an RCA, and some of those were pericare and catheter care. We re-educated nurses during a skills day, and we also added to our daily list of catheters a column to track compliance with pericare and catheter care. We also worked on urine culture stewardship. We sent education to physicians. We also implemented urine culture appropriateness form at the end of 2025 to review each culture before it got sent to the lab for appropriateness. We also implemented a trial avoid algorithm to help standardize that process. Next slide, please. In conclusion, we nearly met our goal. We did see a 35% reduction, but we did end up turning the tide on these infections. We did have a decrease in our CAUTIs, our utilization, and our SIR, and we did that through a daily review of catheter appropriateness, a multidisciplinary CAUTI reduction team, and implementing best practices. Next slide, please. And that's just acknowledgement to all the people that took part in this project and my references. Thanks, everyone.
Awesome. Thanks so much, Jason. Great work. All right. And now we have Brianne.
Thanks, Julie. Hi, everybody. So our poster really focused on simulation and how creating scenarios with something as simple as GlowGerm can really improve staff confidence as well as compliance with infection prevention practices and ultimately helping patient safety. So we did a baseline needs assessment, conducted surveys and audits, and we looked at simulation scenarios that would help develop and reflect real-world challenges. We collected data pre and post simulation to assess perceived confidence and adherence to IP practices, especially looking at hand hygiene and PPE. You can go to the next slide, Julie. So our results, we really looked at the post-simulation survey showed an increase in perceived confidence from 50% to 75%. Audits of clinical practice conducted before and after the simulation sessions revealed noted improvements in both hand hygiene and compliance with PPE. Hand hygiene compliance increased from 68% to 93%, and correct PPE donning and doffing improved from 60% to 88%. Debriefs indicated that simulation sessions were a safe space to practice, make mistakes, and ask questions. Go ahead and go to the next slide. So ultimately, the conclusion is that integrating simulation into infection prevention helps ensure foundational practices are not only taught, but deeply embedded into clinical culture, creating a safe space for staff to practice and learn in order to improve patient outcomes. And that's it.
Awesome. All right. Thank you, Brianne. And thank you to all of our presenters. I'll just quickly open the floor if anyone has any questions or comments. All right. Well, if you do have any questions, please reach out to any of us on the education team. Thanks for attending today, and thank you for all our great presenters. And then just another reminder to sign up for the APIC Great Lake Conference, October 15th. And then our next educational webinar will be in November. So look out for an invite for that. And thanks for attending, everyone.